All right, we're recording now. This is week 6. We've made it. It's halfway. Remember, it's going to get pretty rough right now. There's a lot of projects, community, med-surg gets tougher, pediatrics gets into diagnoses, and they're not exactly adult, the symptoms. Some of them are and some of them aren't. And if it is something that's the same, I'll let you know. So don't get behind. And if something happens to you, remember, let me know before something is late, overdue, that you're having trouble with. I want to know before so that I can help you, because after, I can't help you. Indira, turn on your camera for me, please. So this week, if you noticed, I did turn on the homework grades. I turned on NCLEX case studies, and you could see how they affect your grades. I did send an announcement with it. You still can turn in some week 5 stuff if you need to until Sunday, of course, with a 10% deduction. Now, I apologize. My voice is squeaky, scratchy. I've been sick the last week, but I'm going to make every attempt with my hot tea to get through this tonight. If at any time you don't understand me, again, tell me to stop. I didn't get it. I don't understand it, okay? Next week, we have exam 2. This week, we have reviews all week long. If you notice, we did one today. It was already done. I'll be posting them on your announcements. And I will post them, and then I'll keep editing and adding all the announcements. So it's one announcement. So you don't have to look for all of us, different professors, all 5 of us. It'll be in one place. And I always attach the PowerPoint for the study guide there too. As you're doing these reviews, you're not understanding, please send a message with me. Let's get together and let me help you understand it better. Because there's a lot of concepts that are going to go on now. We're doing respiratory, we're doing cardiac, we have going into endocrine next week, diabetes, DKA. If you don't understand these things, please let me know. So try to make one of those reviews, if not 1, 2, or even better. And remember, all of those reviews will be there for you. Now, one of the things I want you to know is you are actually a really good group with coming to class, keeping your cameras on, and I want to know I appreciate that. It shows a lot of professionalism, respect, and I don't have a problem with it. So I want to thank you for giving me that respect for being here. As I told you, if you need to eat, you have to eat. As long as you're coming, you look professional. I am a happy person. This week, there's a lot of homework too. We have the congenital heart disease and cystic fibrosis, and they're really good case studies. So try to do your best. Quiz 4 is on information from tonight. So as I always say, after you come to class, then do your quizzes. I think you'll have a better understanding. So, as I've said, always do your interactive lecture. So now you've been introduced to the information. You come to class, I give you a PowerPoint, and then we're going to be doing the Kahoots right after. So that's 3 different times repetition. And I think you can see if you're doing that, it really does help you understand it. We also have NCLEX questions due this week. And I've had questions about, can you redo them? You can do NCLEX questions over and over and over again till you get the grade that you want. Just submit that one that you want. Just make sure that you're doing those topics that are what we want for that week. Linda, could you turn on your camera for me, please? Thank you so much. Appreciate that. Any questions? Okay, this week, what are we going to do? We're going to be doing our PowerPoint. Remember, you can stop me at any time, ask any questions. And then we're going to do our Kahoot to follow, which does cover a lot of the concepts. Remember, don't sit and memorize things. What we want you to do is take the concept, see the way I ask a question, but then try to translate it to another situation. What do I need to do with that? What am I looking for? What is my priority? Okay. So memorization, you're not going to remember, but understanding how to work with it. In many ways, you're going to remember these things. All right. Any questions? All right. Let's go ahead. Let's start with our PowerPoint. So hematological and immunological dysfunctions. Well, this is all about blood and what the body does and what's in the blood that will work with these things. So when we talk about anything dysfunction with hematologic and immunologic dysfunction, we are talking about, working with the blood. So how do we understand it? Well, number one, the kid's going to have a symptom. Something's going on. Why are we going to take a blood? We don't just take blood just to take blood. So if it's usually hematologic, one of the big things we see is the kid has no energy. Kids are up, they're active, they're moving. And when they're not, parents are like, something's going on. Because we know that, for instance, if you have an anemia, you have your red blood cells. There's not enough of them. What do red blood cells do? They carry oxygen and they carry food, iron to the body. And without that, they have nothing, no fuel, no energy. So you're going to see them tired. Also, as we get older, we know that the way children eat changes. When they're infants, we can have more control. Iron fortified cereals, iron fortified formulas, and we'll be watching them and maybe giving some vitamins to these children, which have iron in them. If we're seeing constant infections, constant upper respiratory, ear infections, mucus in the nose, coughing, something's going on. The body is not doing what it should do. So it really makes us want to look for it. And then the other thing with blood is if we're bleeding. Now, how would you see a kid bleeding? I think the most common thing I see with bleeding is either a lot of bruising or epistaxis, nosebleeds. And epistaxis sometimes is that one thing that triggers a physician to do a CBC, or maybe bleeding coagulopathies, which is what? Your PTTs, and seeing, are they prolonged, something going on. So red blood cell disorders. Again, remember, what do red blood cells do? They carry oxygen to the body and they carry iron. They feed the body. That's what red blood cells do. So the most common hematologic disorder is anemia with children, and most commonly it's iron deficient anemia, which means they don't have enough iron. So your body's not getting that food it needs. So you're going to see a child which is not going to have the energy that it needs. Now, there's many ways that children can have decreased red blood cells. It could be not producing enough, or they're destroyed quickly, or these are weirdly shaped and then they don't last long, many different things, and we're going to go into that. Now, anemia in children is really defined with those hemoglobins of less than 10. You could see adults might go a little lower before they call anemia, but children is that 10. Now, here's those classifications of anemia. They all have one thing in common if you look at it: fatigue, right? No energy. And tachycardia. Tachycardia is because the body's trying to get oxygen, trying to get iron, so the heart works faster, trying to get it around, but there's no blood cells, there's no iron, there is no oxygen. So the body's working hard. So you could see that there's going to be something going on with the heart. Heart failure could happen if we don't treat these things. Now, nutrition, most common of the anemias: iron deficiency, and then B12, which is your intrinsic factor. That's the two big things that are in nutritional. The other ones that you can see is bone marrow failure. Now, bone marrow, what does it do? It produces cells, right? And if it's not producing them good enough, you're going to have anemia because you just don't have cells. We could see this with aplastic anemia, and we're going to go into that more as we go further. And what do you look for? And then if you have any sort of cancers, and then infections do eat up blood cells a lot. So it could be an overwhelming infection, and it could be a virus, not just bacterial. Then you have an increased red blood cell loss, which means you're bleeding. When you think of bleeding, hemophilia is number one that hits you, right? And it could be that nosebleed, and that's how you diagnose your hemophilia. The other one that we'll see is something called ITP, thrombocytopenia purpura. Oh, that is a mouthful. It's also called ITP. Now, ITP, how I remember what that one is P. P is platelets, low platelets. So immunothrombocytopenia purpura is low platelets. Low platelets is also causing bleeding. What would you see if you saw low platelets? Well, we're going to go into that also. Then we have the anemias which cause an increased red blood cell destruction. And I think the biggest one that we have all heard of is sickle cell anemia. You know, sickle cell anemia has these sickle-shaped cells, but also they die quickly. They don't stick around long enough. Another one is thalassemia, and we're going to go into those cultures with sickle cell and thalassemia. Then we have the extracorporeal, which is immune, which is infection, which could be, you know, a toxic substance, medications, chemotherapy, you know, is one of those ones that, you know, we need it for cancers, but it does destroy red blood cells. So what do you see with anemia, and why is it such a big deal? Well, I've sort of mentioned it with the heart trying to work harder. But how do we know anemia? Well, number one, you can see a child which is paler. And then you, through that history, that physical you do, we also see a kid who's fatigued, doesn't have the energy that they used to have. So we do our assessment and we listen to the heart. Well, in a normal patient, the blood is thicker, so you don't hear swooshing. But when there's less cells, they sort of hit each other, and you're going to hear murmurs in the heart, okay? You also, because you have less red blood cells and the body wants more iron and oxygen, your heart is going to beat faster to try to get this oxygen and iron around, but with less blood cells, it's not working. So it continues to work harder and harder and harder. So you hear a murmur, and because the heart's working so hard, you can go into failure. So treating anemia is really important. If it continues and goes on without treatment, which how do you treat anemia? Well, we either give blood, we give iron, you know, to help produce more cells. Now, you're going to see cyanosis because all of the oxygen the body's going to try to keep to its major organs, try to keep the brain and the heart and the kidneys and everything with all of the oxygen it needs. So maybe peripherally, you're going to see cyanosis, you know, around the lips, circumoral. You might see it in the hands and the fingers. And your body's not getting nutrition. What do we know about nutrition? Nutrition, nutrition. If you don't have enough nutrition, what happens? Anybody?
Growth development stops.
Right. Growth development, your cognition, everything. It's the same with food or the body getting oxygen and iron. Good. Thank you. So how do we manage anemia? Well, I've already talked. History, physical, absolutely. And if we're suspecting anemia, we're hearing that murmur, or we're seeing bruising, bleeding, petechiae, any of that, we're going to do a CBC and maybe more other type of bleeding coagulopathies, PT, PTT. We want to see what's going on, what's happening. If we are with severe anemia, you will get a blood transfusion. But remember, that's not treating the what happened, what's the cause of it. It's only treating a symptom. but we need to get oxygen. We need to get the iron into the food and feeding the body. So we'll give blood transfusions. Now, I want to ask you a question. You have a child getting blood, and all of a sudden spikes a fever, gets a rash, and you notice this. What do you do first?
Stop
The infusion.
Stop it. Absolutely. Because the body's reacting to it. So immediately we turn it off and we call the physician, let them know what's going on, and get whatever orders we need. Really, very good. Another thing we do is if it's nutritional, we're going to do a nutritional intervention, whether it is trying to get the toddler to eat broccoli, which you know is sometimes really hard. Unless you're my grandson, this kid will eat a whole plate of broccoli and be happy. It's like he's eating chocolate. It was quite amazing, but most people aren't like that. Kids don't eat like that. So nutritional intervention. And during that moment where they're in those low blood counts, and it could be 5 and 15, 6 and 18 hemoglobin hematocrit, we're going to, first of all, before we get that blood, we're going to give fluid because we need to fill up the intravascular spaces. We need to make sure there's enough volume circulating. That's number one. We'll give them some oxygen, but I'll ask you a question. If you don't have cells, how are we going to get oxygen to the body? Does it really work? And it is questionable, but you at least to make that attempt, okay? And then, of course, we want them to rest. We don't want to have them expend energy because they don't have any. They have no reserves. So as we're assessing the child, the age of the child makes a difference. Racial, ethnic background. What is one blood disorder that you know that could be due to race or ethnic background? I think you all know this one.
Is it thalassemia?
Thalassemia, yes, and sickle cell disease, right? Both of them, and we're going to go into those too, but looking at that, it could sort of give you a hint. And then you always rule out active bleeding. Don't assume it's something. It could be a GI bleed, could be an ulcer, and kids do get ulcers. So a stool for occult blood, that rules out any sort of bleeding. Now, children, especially, I mean, the young ones, yes, but there are some really scared adolescents also. Get them prepared for those laboratory tests. You know, use that numbing cream, use distraction, use child life, have them held in the parents' arms, because if they have anemia, they're going to be getting frequent blood tests. And you don't want this kid who's already with very low iron and oxygen getting upset, screaming and yelling. They're burning up their oxygen, and you could actually cause more problems. So have that kid very well prepared, get on their level, you know, sit down with them, get them, you know, so they're not so scared, and then use all those distraction devices. And it really does work. And you could draw blood easier with one stick instead of the kid moving and, you know, causing more problems. So always with anemia, decrease those tissue for that needs for oxygen by keeping them calm, not expending energy. And we're trying not to have complications with these kids. So iron deficient anemia, don't get enough dietary iron, okay? Which means, do we need to teach parents and children about what has iron in it? Well, maybe some of them don't know. So sometimes a dietitian needs to come in. Usually iron deficient anemia, we can prevent it either through nutrition or supplementing with vitamins. It can get to the point where instead of just oral iron, we might have to even give iron dextran. Do you remember how to give iron dextran? Do you remember from pharmacology?
Z-Track.
Yes. And why is it Z-Track? Because it burns and it will
And
stay.
stains. Yeah.
Absolutely. Very good. So adolescents, we know they don't eat well. They're all into that body image. I'm too fat, or they just grab a bar and a bottle of water and run for the day. So adolescents might be a harder one actually to treat than the younger kids. Also, as infants, we're giving them all that iron fortified cereal and formula. But by the time they get to be 1 year old, we put them on whole milk, right? Does it get the iron? No. So that could be that change that causes them to go into iron deficient anemia. So it's something to remember and to tell the parents that we need to give them something. So can we treat iron deficient anemia? Yes. How do we treat it? Again, diet and supplementing. And then of course, iron supplementation, whether oral or those Z-Tracks. Sickle cell anemia. What is this? Well, I describe it as you have your blood vessels and you've got these sickle cells, and then the blood vessels bifurcate. And if you don't have a very hydrated, well-hydrated child, because kids don't like to drink unless you say, here, take this water and keep drinking, right? You have to encourage them. Well, when it bifurcates, those little cells get stuck. And then other stuff can't get through. So you've got this buildup of cells causing swelling, and below it's not getting any oxygen, right? No cells are going there. And it could cause death of tissue, and it causes the swelling, which causes pain. And it could cause, all of that tissue to get really inflamed. Now, sickle cell, we know, is African American. Many people carry the trait. They don't have the disease, but if both parents do have the trait, 25% of each child has a chance to get sickle cell disease. Remember, sickle cell disease is an immunosuppressive disease. So these kids need a little extra special attention with making sure that we do not give them infections. As in all patients, you want to do good hand washing, but immunosuppressed people even more. So with all of this obstruction and this red blood cells are always dying and low hemoglobin, hematocrit, these children can have death of the tissue. It could also cause all of this pain, and it could be anywhere in the body. Now, one of the things that we don't think about is a kid with a headache. What if they're sickle cell? Do you know they can sickle cell? They can have a sickle crisis in their heads. So don't ever think that it's only in an arm, a finger, a knee. They have chest syndrome, which sort of mimics pulmonary embolus, if you think about it. It's sudden and increasing pain in the chest, or it could be in the head. So if you have a child who has history of sickle cell disease and they're complaining of headache, what are you going to do?
Hematocrit and hemoglobin levels.
We're going to do a neuro check. We're going to check pupils, check strength, see, are they having a stroke? Okay. This is some things that nurses don't think about. They only think of a knee or somewhere else. So it's just something to remember about. So what happens? How do we get sickle cell crisis? Well, we know that these cells are sickled, and we know it takes a lot to get through the blood system because they can get caught up and kinked really easily. So keeping them well hydrated is number one, okay? If the vessels are big, the blood's gonna flow. But what happens with kids? Well, they could have trauma. I mean, that's something that can cause swelling and can cause the blood not to be able to go through. If there's a hematoma, it occludes it. Infection and fever are number one. You have a child with sickle cell, they're all taught, you have a fever of 100.5, you need to tell your physician, and you need care immediately because remember, they're immunosuppressed. Okay, so they need treatment immediately. So this is very important to let them know. Now, stress, all that emotional, physical, that can cause sickle cell. And then anything that causes dehydration. If they're out, because we want them to be treated normal, right? We don't want them to be treated like they have this disease. They are normal, but if they're out running around, playing sports, they need to have that water next to them and actually something with electrolytes better. Because remember, we worry about potassium with these children and electrolytes. So we want to make sure that the blood flows through, and you keep the pipe open, blood flows. Dehydration with all that sweating, it's going to close. You're going to have a sickle crisis. So,
Dr. Bogart, I'm sorry.
sure.
Potassium, you mentioned potassium.
Electrolytes,
What?
because
In
the
general?
sweating,
Gotcha.
right? Loss of fluid. What do you see? Anything with loss of fluid or urinating too much. What's the first?
You lose potassium in swimming.
There
Gotcha.
you go. Yes, very good. Yes. So how do we treat a sickle cell crisis? Well, the kid's going to have pain somewhere, and they'll tell you. Number one, we know that there's a lack of oxygen, so we want to keep what's there and use it. So rest. Keep them under minimal energy loss. We want them to rest. Number one, it's sickle cell crisis is because it can't get through the pipe. Those vessels are tiny. So how do we open those vessels? How do we get that blood flowing to relieve the pain? Because, you'll say number one priority is pain control. What have you done? You've treated a symptom. You didn't treat the cause. The cause is those vessels are too skinny. How do we treat it, make it fatter? Number one is IV fluids. Now, it doesn't mean that I'm going to start that IV and start that bolus. I'm going to have the pain medicine in my other hand, but I'm going to relieve what's causing that pain and give that pain medicine also. The other thing is heat. It dilates vessels. So now we've opened it with heat, we've opened it with fluid, we've given them their medicine. And then usually I told you, these are those children that are immunosuppressed. Usually infection is what you see as the big thing that causes it. So antibiotics, very important that they get that. Now, when I tell you sickle cell, I've told you that those cells die really quick. Those cells, you'll see hemoglobin hematocrits on children with sickle cell crisis could be 6 and 18 hemoglobin hematocrit. Not uncommon. So be ready after all of this. Most of them who have gone into the emergency room, I've never seen a kid with a normal hemoglobin hematocrit having a sickle cell crisis. It's always they're going to need blood. So we'll get the blood and we'll give it. And again, we're giving blood with oxygen and iron to these children, giving them what they need for their body to keep it, the child alert and oriented and feed the body organs, etc. Now,
I had
one
a
thing
quick
that,
question.
sure.
I'm sorry. So I had a friend I used to work with who actually had sickle cell. He worked with me during COVID, and he had to go get transfusions done every month. Is that a normal thing for a child as well?
Some do, some don't. Not every child acts the same. That's why I love pediatrics. They're all different. But remember, those cells don't last long, so they die quickly. To get it every month, that's quite a lot, actually. But it's not unheard of because those cells die quickly.
And is that replacing the cells or is that blood? I never knew exactly what kind of, transfusion that is.
It's a blood transfusion. Usually it's packed red blood cells. It's giving them the cells, the red blood cells they need for oxygen. So the body needs it because the body can't make them quick enough. And the cells that are being made die quick.
Okay, thank you.
Okay, that was a great question, Ashlyn. Okay, children, because remember, they're immunosuppressed. Their body doesn't fight infection well. The young kids from 2 months to about 5 years old will get 1 pill of an antibiotic a day. Usually it's PenVK, penicillin, unless they're allergic to it, right? But it's there as a preventative. They're also going to be monitoring their reticulocyte count. And this is telling you how is their bone marrow working. And blood transfusions, I've said it over and over again, but if given in the crisis, we're replacing oxygen. So we're reducing ischemia in the body, keeping the organs and the brain, keeping you alert, and it's what's needed in sickle cell. Prognosis. Well, there is no cure. They do give bone marrow transplantations at times. Remember, these children, many of them are in and out of the hospital, and the parents and family members have to be there for them. So it is a family affair. Be very supportive of them. They do have frequent bacterial infections. And what do infections do? It causes fevers, which causes dehydration, which causes sickle attacks. So very important that the family and the children, and also siblings, are very aware of what's going on. The bacterial infection is what causes the death in the younger children if we don't catch it quick enough. That's why temperature of 100.5, and it's really not a big temperature, is it? But 100.5, we know it's just going to get higher. Get them to the doctor. We know that they can live into the fifth decade if they're on top of the sickle cell and they treat themselves and go to physicians as needed. So understanding early intervention, that low-grade fever, I'm feeling the pain, get to the doctor. Taking the penicillin if they need it. And as I was talking about that respiratory, well, they also can have a stroke, they know that we have stroke sometimes. The headache could be that something they're telling you. And remember, respiratory could be looking like a pulmonary embolus. So very important that we recognize them early and treat them. How do we treat sickle cell? What's the first thing we do?
IV fluids.
IV fluids, because it opens up those vessels, right? And it gets that blood flowing through. Very good. So treat the kid normal. Let them be normal. Let them play sports, but tell them the importance of hydration. And teaching these children is important. Keeping their stress levels down. All right, the other blood disease, which is from a culture, is thalassemia.
I got one question.
Absolutely.
So my son, he has sickle cell disease, but he was diagnosed a long time ago. I'm an old lady. He's 31 years old. So back then we were giving him hydroxyurea. Do they still do that now?
I haven't seen it given, no. The last things I just seen is, but remember, all children are different. I know what that's used for, but usually it's just prophylactic antibiotic.
Yeah, he took that for a while.
Acid. Yeah.
But once he became a teenager, he didn't need it because he has the SC disease. So he didn't actually have to use it for a long period of time.
Well, that's awesome. You don't look like you have a 31-year-old, ma'am.
I got a 35-year-old too.
Oof. Well, God bless you.
When she said that, I looked and thought, she's not much older than 31. How can that be?
No, girl.
I know. Wow.
I can 50.
Good for you. Good for you. Keep it going. You're doing awesome. Okay. So thalassemia is Mediterranean people, descendants living around there. I call this the rectangular cells, okay? There is a shortened life of these. Now, red blood cells, what's inside of red blood cells? Oxygen and iron, right? Well, these cells burst. So oxygen, it's not going to work because it's burst. And it also has iron in it. Now, too much iron can cause problems, right? That's the biggest thing that falls into thalassemia. So let's look at these different types. Well, you can have from minor to major, and it all depends on how severe, how quickly cells are bursting, and how many are, okay? When it comes to the thalassemia major, it's also called Cooley's anemia. This point of thalassemia, these children, which grow into be adults, need transfusions to survive. Now, how often? Well, they're all different. It could be every week, every other week. They're all different. So every patient would be different there. Now, we don't see it immediately at birth, because remember, you have mommy cells at birth. And then your cells start to go away. And then all of a sudden, about 6 weeks of age, we're starting to see it. Now, in nutrition, How do we know if they're not getting enough nutrition? What would you see on a 6-week-old?
Delayed development.
It could be cognitive delays, but it also could be they're not gaining weight, right? Because whenever you're measuring nutrition, which red blood cells are nutrition, it's oxygen and iron for the body, it feeds the body. If we're not getting enough, these children are going to be cognitively delayed, but they're also their growth. They're not going to be gaining the weight and the height the way they should. Why do you think we do height and weight on children every visit? Whether urgent care, doctor, doesn't matter. We got to see, are they growing? Are they growing? So that will say, all right, we're not seeing that. Maybe they look pale. We're going to do a CBC. And that's going to show us, that blood smear is going to show us those cells that are shaped differently. And we're going to be watching them. Now, blood transfusions are what we need to keep the hemoglobin hematocrit levels high enough. We can't give iron because it's not iron deficient. These cells burst. We just need to replace the cells. Now, because of the amount of cells bursting, and if it's quite, a lot, and it's dying quickly and bursting, these children have too much iron in their body and it can be toxic. So we can do two different things. We can give a medication, the desferal, okay? And it binds with the iron, it goes in the kidneys and you excrete it. Or they may need to have something similar to dialysis, which is called apheresis. And what's neat about apheresis, nurses run the machine like dialysis, but you can pull off a component in the blood you don't want. And in this case, we're going to pull off the iron. How frequent is apheresis? Depends on how many cells, how quickly they're bursting, and how quickly the iron levels are getting elevated in the body. Can you imagine how many blood samples, how many IVs and pinches and sticks these kids are getting? These children need really good teaching. They really need to understand so that we can keep them from getting absolutely crazed every time they go to the doctor. I mean, running down the hall, and I've seen kids turn around, run out the hall, and run out of the ER, and you're yelling, security, get that kid, because they're so afraid of a needle. In Miami, they say no pinche. It's the Spanish thing, no pinche. It means don't stick me, no needles. So how do we treat thalassemia? Well, it's oxygen being burst. That means the body don't have oxygen, and the iron is being in the blood system. So you got two things to deal with. So we're going to need transfusion to give that oxygen back to the body and to give that iron back in a form that's not toxic. So make sure that these children are compliant. It's a lot of work on the parents and the child to get to go to the doctor, go and get transfusions, get chelation therapy, taking the medications. So again, keeping that child being able to cope with it. It's the family, it's the whole family. And remember, if you're giving blood transfusions, the chances for reactions increase with the amount of blood transfusions you're getting, because it could be weekly. What is your prognosis?
I have a question. I'm sorry.
Absolutely, no problem.
So with thalassemia, when you give the blood transfusions, what prevents those red blood cells from bursting? Like what's causing their own production of bursting, and what prevents the blood cells that you're giving them from bursting? Does that make sense what I'm asking?
I think it has to, I'm not totally sure, but if I had to deduct, but I can get back to you about that. Could be the way the body accepts it and the spleen accepts it, and maybe the combination makes it, but
I have a
ahead.
question but like in regards to what Heather just said, they still destroy those red blood cells that they receive. So they're destroying their own and the ones that they transfuse. That's why we have to continue transfusing them. Is that right? Like, because it's not like they
basically.
don't destroy those, right?
No,
Because
So
that's
then
why we
aren't
have to keep
it'd be great if they accept them and they just kept them, but all of them are still going to burst.
So then aren't you just adding to their problem of having excess iron at
Well,
that
you're
point?
giving them the cells that they need, because if they all burst, there's no red blood cells left. Your hemoglobin and hematocrit go down to the floor. So there's nothing there. So you give those transfusions, you're supplementing, giving them that oxygen they need for the body. Yes, they go away, but you are, at least they have something to work with.
Okay.
Can you imagine that heart? You go from anemic, you give blood, it's up and down and up and down. That heart works so hard because of those periods of anemia. Because remember, murmur, tachycardia, beating faster. So they go into heart disease. So they need to really keep up close with these sort of things. One of the things they do for treatment is take out the spleen to try to stop those cells from being produced, to try to help with the, to slow down the amount of cells being destroyed, okay? And then, of course, you're not having oxygen, iron, that the organs are all suffering. So you can go into multi-organ failure. Bone marrow transplant might be a cure, but it's still a potential. Now, aplastic anemia. This is another anemia where all formed elements of the blood tend to be very depressed. You don't have red blood cells being formed. Leukopenia, you don't have white cells being formed. No white cells, no immune system, right? And then thrombocytopenia. You know, thrombocytopenia is low platelets. Remember, platelets have to do with blood coagulopathy, right? If you don't have platelets, you're going to bleed. It's sort of like a hemophilia. It's not a factor of it, but it's a component. And any child can be in thrombocytopenia. You know, think about leukemia, and we're going to go in a little bit later tonight to talk about it. But their platelets and hemoglobin hematocrit are very low because, you know, chemotherapy does that. And one of the things is the platelets can cause bleeding with it. So thrombocytopenia is quite serious. There is a hypoplastic anemia where just the red blood cells are being not formed as quick as they should. And the others are white cells and platelets are there. But when we talk about aplastic anemia, we're mostly talking about pancocytopenia. It's usually the one. So aplastic anemia, how do we treat it? Well, number one, we're going to see platelets down, white cells down, and red blood cells. Hemoglobin hematocrit is going to be really low. And again, we don't have an immune system because of the white cells. So immunosuppressive therapy is given and a bone marrow transplant. We treat this child similar to leukemia. And we're going to go onward, and we're going to, a little bit later in lecture, going to go into leukemia and the care management of that. Now, when you think of defects of hemostasis, which means you're bleeding, what's the one diagnosis you think about? You're bleeding. Hemophilia, yes. Very good. Hemophilia, it's a X-linked recessive disease where the mother gives this to the child. And hemophilia is just not one thing. It could be anything that helps the blood clot, causes the blood not to clot, so you bleed. You can't put a finger on it, it won't stop, it just keeps bleeding. There's nothing that can help that blood to stop. We need to just give that factor. Now, what type of hemophilia do we see? Well, there's hemophilia A, which is factor VIII. This is the most common. This is what you think of, factor VIII. Hemophilia B is also Christmas disease, and it's actually factor IX. And then there is another type of factor that some scientists named von Willebrand said, all right, this is what I say. We're not going to say factor 10. I want my name on it. So it's a von Willebrand factor, but it's a combination. His factor that he found and factor VIII. How do we treat a kid who's bleeding and we know it's hemophilia? We replace the factor, right? We give them the factor. So How do we diagnose hemophilia? Well, as I said earlier, sometimes we take these bleeding problems and we find them out by a nosebleed, epistaxis. They're having chronic nosebleeds, and they're wondering why. Well, initially they think, oh, he had a cold. Let's put some little Vaseline in there. Probably that, it's dry. And it works, but then it starts bleeding again. And you're having reoccurrent epistaxis. So they go ahead and they do blood tests. They're going to do, of course, a simple CBC, but they're also going to be looking at your blood coagulopathies. We're going to look at your PT, PTTs, these things called fibrinogen, parathyroid hormone levels, and these things all play a factor into clotting. If you don't have these things or things are prolonged, you are going to bleed. Now, hemophilia, again, is X-linked. It's from mommy again, okay? Now, in hemophilia, factor 8, factor 9, one of the things that you will see in the blood test, which is a quick thing to look at because sending them away to find out what factor takes time. You have to send them to that special lab, et cetera. But you will see a prolonged PTT. Now, you think of an APTT or a PTT, you think of heparin, right? Because we measure heparin by the PTT time. Well, these children aren't on aspirin, they're not on heparin, and we have prolonged PTT times. We could sort of say, I think this child has hemophilia. And that's usually the clue there. Now, their platelet count is normal. Parathyroid level and the fibrinogen, which also has to do with blood coagulopathy, they're all normal. But just that PTT is elevated, it's nice, at least we could see something quickly. Okay, I think it is. So we know sort of what to do for these kids. So how do we do this? Well, I had this little boy came into the ER one Saturday with his dad. He had fell down and he fell on his knee and it was bruised and he didn't know if he should be giving this child his factor. And it was factor 8, if he should be giving it at home. And he came into the ER because he couldn't get a hold of hematology. So the doctor looked and said, yeah, you need to give it. He had brought the box and the equipment and he said to me, do you mind if I give our stuff? And I went, the doctor, he said, okay, went in, said, go ahead. And I watched this father and his son sit there, pick out the vein. He mixed up the medicine. The son actually held the little butterfly as the father pushed it in. His way he did it was amazing. And this kid was involved in it. And this father did almost as good job as I do. And I had an orientee who watched it. And it was one of the sweetest things I've seen, that such a trust in each other to give this factor. And they give it at home. Whenever you have fall down, there's bleeding, they can give that factor right away. And the way this father did it, I was totally impressed. To this day, you can tell I was impressed. Now, sometimes we can give desmopressin, and sometimes it's a nasal spray. Well, that's easy. If it was that easy, it would be awesome. But this is only for mild hemophilia. Sometimes it is IV. Now, desmopressin, DDAVP, is also used for something else. And we're going to learn that next week, and that's diabetes insipidus. So desmopressin could be used for hemophilia or diabetes insipidus. And we'll talk about what that is next week. And then aminocaproic acid also helps. Now, kid falls down, is bleeding, has an open wound. What do you need to do? What do we need to teach these children? Because we're not going to be there when they fall down. We're going to see them after they come to the doctor or the ER or whatever. We're going to, number one, keep the environment safe at home, especially your young toddlers. You're going to pad like the sides of your coffee table if they're sharp. Anything that could cause an injury, we're going to protect that environment. for that child. That's number one always. We don't want them to get cut, so we'll protect them. If they fall, something happens, they're cut. Number one, they need to rest. They need to ice it, they need to compress it and elevate it. And this is just like getting a sprained ankle, right? Exactly the same treatment. Now, the ice does what? It constricts vessels, right? So they're not going to bleed as much. Compress it is like trying to put your finger and, holding it so it doesn't bleed, and elevate it so that we keep the blood, the heart is not pumping as hard. So hopefully we can close it. And of course, we'll be giving that factor at home if that's what the physician has told them to do. Now, hemophilia, you can have a pretty normal life, but again, remember choices and stuff, that they do bleed easily. So making choices for what they do, for fun, for sports, we have to be careful with. Now, the one thing about hemophilia is they fall down on their knee, their fingers, bump their toes, and they're constantly bleeding in their joints. Blood is irritating and it destroys joints. So our goal is to protect those joints so that they don't end up in wheelchairs as they get older, because it can be that severe, that blood, it's like caustic to the joint. They are working on a gene, but they're not there yet. Immune thrombocytopenia purpura, ITP. Platelets, right? P, platelets, ITP. P is platelets. What does that mean? Well, your platelets are low, okay? Now, how do we usually find this out? Because this isn't something that you're usually born with. It can be an acute, which means something that happens that will go away after treatment, but it can turn into a chronic condition too. Usually after an upper respiratory or some sort of infection. And what would you see? Well, do you see that arm with that little petechiae? You're going to see children with bruising and petechiae, nosebleeds. Epistaxis is a big thing, again, that they go in for, bleeding problems. And it's, chronic, and now the parents are getting worried. And this is just those symptoms that you'll see. And what do? These children, it's nothing to do with their blood vessels. This is only you'll see bleeding in the nose, petechial, and you'll see hematomas. What we need to do is put them on bleeding precautions. Low platelets, that means you're not going to be able to clot easy, right? So as a nurse, what does that mean if I know this child is ITP, or if an adult has ITP? Well, anything I do to that patient, that client, with a needle, can make them bleed. So no venipunctures, if at all possible, or minimize them, okay? We're gonna watch them for bleeding. Soft toothbrushes, right? We're gonna watch their stool and their urine. If they're in the hospital, we're gonna be watching their CBCs. We're gonna watch those platelet counts. And sometimes these children get corticosteroids, that they do sometimes can help. The main treatment is immune, which means it is not bacterial. It's the immune system, right? So we're going to be given IVIG, intravenous immunoglobulins, to help build up the immune system. And they give something else called anti-D, and that can correct the ITP. And they say if this goes on and they don't correct it within a year, it could become chronic, but usually they can make it acute and they can treat it. And then this child will not have this for life. It's not a lifelong thing. Now, I've mentioned epistaxis a couple times. So as I said, it could be due to some underlying disease. As I said, when you first get it, it could be that you were sick, your nose was dry, put a little bit of Vaseline with a Q-tip in there, morning and night, and sometimes that works. but sometimes they continue bleeding, bleeding, bleeding. That's when you start looking for what's the cause. You know, the symptoms bleeding, what's the cause? How do we treat it? Well, you take your finger, forefinger and your thumb, push it tight, and you lean them forward. And why forward? We don't want them to swallow the blood because then they'll vomit, right? And if they have epistaxis, they vomit, that upheaval is going to cause it to bleed more. Have them sit forward for 10 minutes. If after 10 minutes they continue to bleed, they need to go get help. Go to urgent care, go to ER, go to somewhere. A lot of times they'll put what we call is nasal tampons up there, which will put pressure and it will help stop the bleeding. And then they'll look for the causes. An immune issue, HIV, AIDS. You know, when we talk about the pediatric population, we can talk from birth up into adolescence. So mothers known HIV, if they put on this heart therapy, it is a highly active antiretroviral therapy. It's an antiviral, okay? It's something to help boost this newborn's immune system. And then right after they're born, they're put on antivirals. Again, we're trying to boost this newborn's immune function. Now, I've seen a couple different cases with newborns, with mother with HIV. I saw one that had triplets, and these were at where Cutler Bay goes for their clinicals, the pediatric clinicals. And all three triplets were there. One of them had AIDS, one of them had HIV, and one of them had nothing, absolutely normal. So it doesn't matter that the mother had it, all outcomes could be there. Another thing, which I thought was amazing, is I started working in the newborn ICU and they started with more understanding of HIV/AIDS. Children, infants that have been given antivirals, if it wasn't before birth, at least at birth, some of them can zero convert and HIV is gone. After a year, they can be non-HIV with treatment. And I think that it's giving that child that chance. Not all of them, but it can happen. So we need to understand the mother's HIV. We need to institute treatment as soon as we can. And again, what is our goal for newborns? We want to boost their immune system, right? Now, there are some opportunist infections, you know, respiratory, PCP pneumonia, pneumocystic carny pneumonia. And again, we'll treat that. Something we look for. We start seeing respiratory distress, we know what's going on. Another one you might see is that yeast infection, candida, right? But the most one that we're concerned about, and that's about 3 to 6 months we might see those things, is to watch out for pneumocystic pneumonia and give treatment as soon as we can. Again, antivirals, because it's caused viruses. Now, adolescents, you know, remember when you're talking with adolescents, get on their level, right? You're going to ask about their social life, you know, start talking about, so I heard that music. Who was the name of that group? I really like that. Or, you know, again, getting into and opening that line of communication and finding out, are they having sex? And if they're having risky behaviors, you know, and teaching them about hand washing is number one with anything with disease, right? But usage of condoms and abstinence, of course, is the best, but you know, adolescents going to do what they want. But at least we can, you know, to try to help adolescents prevent maybe one case from not happening, going into HIV. Remember, HIV, there is a lot of confidentiality about it. So this is something that you have to be very, very aware of, because you don't want everybody to know or to hear about, you know, they got HIV. I mean, it's nobody's business except that child and those parents. Now, when we're talking about hematological or immunological diseases, we do different treatments. Well, blood transfusions. Packed cells, we can give platelets, we can give fresh frozen plasma, we can give just little components of the blood. So remember, there's always a way that we have to give blood. Always follow whatever your hospital's plan is. What do they say? Take your vital signs before, 20 minutes later, and hourly after, over 4 hours with a pump. And of course, you have a reaction, turn it off. And reaction could be coughing, gagging, like overload, circulatory overload, could be rash, could be a spike of a fever. So I've seen all of the above. As I said, apheresis, and that's a picture of a machine that sort of looks like an apheresis machine, looks like a kidney dialysis. But remember, they can just move a certain component. It could be that insulation therapy, getting that iron out. It could be just the iron they remove. We could just take out platelets. We could just take out whatever it needs to be taken out. Remember, sometimes we have donors. We do apheresis and we can take out platelets, just platelets. Instead of taking out 500 mLs of whole blood, we could just take out what we want. Bone marrow aspirations hurt. They go, and if you've ever heard it, you hear like a crunch going through a bone, whether it's the hip, whether it's the sternum, so today we're so much better than we have been. I've seen such great advances with putting an amyloid cream down and then waiting and numbing it, and then putting numbing medicine down even lower. So it's less painful than ever. And we do give pre-medication to these patients. Younger children, sometimes we even put them to sleep because it is like that. Sometimes we do, sometimes we don't. But remember, be honest with these children. Let them know it may hurt, but we'll do everything possible to make it as little as possible, okay? So both parents have sickle cell trait. What's the chance that each of their children will have?
25%.
Yes, ma'am. 25, thank you. So neoplastic disorders, we're going to go into some cancers, tumors, and we're going to go into blood disorders too with cancers. So the leading cause of death from disease in children past infancy is neoplastic disorders. And about half of them are blood or blood forming organs. These are your leukemias and your lymphomas. Now, leukemia is two types. We have acute lymphocytic leukemia, which is ALL, and then we have acute myelolytic leukemia, AML. ALL is easier to treat, easier for cure than AML. AML is trickier to get rid of and eradicate, okay? Usually these are white children, less than 15, and more frequent in boys greater than 1 year old. Most of these children are 2 to 5 years old. And it breaks your heart when you see working in the ER, you get these children sent by the physician to do lab works and you find out their white blood cells are low. My next door neighbor was 14 and found out she had gone to the ER. She was complaining of being really tired, no energy, had a fever, she had bruising, and she had really severe bone pain. Those are what she went in with. They did that CBC and a blood smear. They found that she had those unrestricted proliferation of immature white blood cells. These white blood cells, they're immature, they don't work. And her blood level of her WBCs was 0.1. What's the normal white blood cell count? 5 to 7? Depends on your lab, but at least a whole number, 5 or 6, right? So 0.1 means she had no immune system. your liver and your spleen are very affected by it. And, you know, it does act like a solid tumor, these things. Now, how do we evaluate? How do we figure out that it's leukemia? Well, all those symptoms I just said are so classic leukemia. You know, that tired, you know, the fever, the lack of energy. Leukemia's white cells are low, but usually you're going to see hemoglobin hematocrits are low due to this this infection that's going on with this fever. And then usually your platelets are low too. That's why the bleeding, okay? So we do a blood smear. We look at the white cells and we go, okay, they're immature. This is leukemia. Then they figure out which cell it is. They do a lumbar puncture. They want to see, is it in the central nervous system? And then they do a bone marrow aspiration. Again, be honest, it hurts, these bone marrows, but again, it's better than it used to be. Now, we've decided it's leukemia. We've given this kid, usually they put a port in these children, so they're not always stuck with needles, and it's an easier way to collect blood, et cetera, et cetera. And there's 4 stages that we do. And the first stage is called induction therapy. And it's 4 to 6 weeks of multi-type of chemo drugs. Could be 2 or 3 different types. And we just blast this child with this chemotherapy. In that 4 to 6 weeks that we're giving this, we have a goal of remission. You're like, oh, remission? Well, gee, it's not that fast. Well, there's always a couple little cancer cells left. So the rest of the treatment is eradicating all those other little pieces of cancerous cells and getting them out of the body. We do it intrathecal, we insert it right into the central nervous system, and then we also do, in the end, just maintenance, just to make sure that it is gone. So the first 4 to 6 weeks is induction. Our goal is remission. We want those cells gone, those cancer cells, get them out. Now, we do a hematopoietic stem cell transplantation for leukemia. And the one thing about stem cells, there's not a blood type. You don't have to have like A positive. There's not what we call A positive stem cells. You can have it from relatives, non-relatives, it doesn't matter. You don't have to be matched at all, okay? And the one that we use a lot, you know, because today we have that ability to save our umbilical cord blood. Now, not everybody can afford it, it's expensive, but if we have maybe a history in the family of leukemia, we might take on that expense and keep that umbilical cord blood. So that would be their own blood cells. So there's 2 different names, and this is how I remember them. Autologous is my own cells. Automatically, it's mine, right? Automatic, it's good, it works. Allogenic is everybody's, or all people, everybody. So autologous is my own cells. Allogenic is everybody's cells. So that's the difference. Now, just like an organ transplant, there can be, you know, this rejection. We call it graft versus host, and it can affect and it can cause severe organ damage. Now, this is about a 2-year-long type of treatment. Yeah, it's 4 to 6 weeks induction. It does eradicate and eliminate the cells, but it's a long-term, constant back and forth to the doctor. One of the things about this is, remember, we are destroying all of the cells in the body, the hemoglobin, hematocrit, the red blood cells, the white cells, the platelets. So this child's going to be getting a lot of blood transfusions. This child is immunosuppressed. These children are going to get infections, you know, just, you know, mom and dad, you know, are home. As much as you protect them, it's still going to happen. So these children are taught, just like sickle cell, a fever of 100.5, you need to get to the physician right away. And they usually send you right to the emergency room to get a dose of IV antibiotics. The quicker we get it, the better it is. We've treated it. It hasn't gone in and taken a hold of the body. The other thing is hemorrhage. Remember, platelets are low. So they are going to bleed. And anemia, hemoglobin, hematocrits are low. They are getting a lot of blood transfusions and platelet transfusions. These children require that chemotherapy, and it's a very caustic, very dangerous drug for us nurses to handle. And nurses are given training courses to handle it. But let me tell you something about working in oncology. Especially pediatric oncology. Now it is rough. Emotionally, it is a rough area to work. But if you get trained, you can actually get like $25,000 sign-on bonuses to work at a hospital for 2 years with certification in chemotherapy. Now you're going to say, but I can't deal with all that death and dying. Well, not all children die. And remember, not all patients, no matter what their diagnosis, not all of them live. And it's not that they died. It's what did you as a nurse do for that child and for that family when they were alive? As I've told you, I worked in cardiac ICU for many years, and not every child made it. But 20 years later, I still have mothers and fathers that are still in contact with me. And it becomes a lifelong bond. It's because you gave them the dignity with their child and you made them feel important, and it can be extremely rewarding. I cry, and it's okay. And I'm there with the parents crying. Give me one of those tissues here, one for you too, and we'll just sit there and hug each other, and it's okay. Prognosis of leukemia depends on what was their initial white count. If it was 0.01 versus 0.1, it's a big difference. How old were they? And was it the ALL or was it AML? And boy or girl? And then the karyotype. What blood type are you? Remember, they're getting a lot of blood transfusions, platelet transfusions. If you are a very hard to match blood type, you're not going to get it as quick as you could, and it could cause problems. So that's what that is. Now, talking about kids with cancers and treatments, let's go over that. Cancer we can treat with surgery, chemo, radiation, depending on what it is. Combinations of maybe one, maybe two, maybe all three things. We know chemotherapy is trained nurses, and they have to be experienced. And usually they are through some sort of venous access device, like a port. Usually they have a port underneath the skin so that we can access it as we need it. These parents know if they're coming into the ER with a child with cancer that has a fever, they know they're going to get blood. So they have little EMLA tubes at home, and they'll put it on, put a Band-Aid on, and send them in, and it will be numb by the time they come to the ER, and we could draw blood, and the child knows it's not going to hurt that bad. In fact, it doesn't really hurt much at all if they've kept it on for a while. Remember, as early as we find out what's going on, the better it will be to put these kids into remission. As I said, the first couple of things you're going to see is pain, fever, ecchymosis, and maybe petechia, some bleeding going on. And of course, that lethargy. These are things that you might see. In some cancers, you're going to see these enlarged lymph nodes, and you also could see problems with vision. Side effects of treatment? Well, there are something called neutrophils, and these are part of your white cells, right? And you should have a normal neutrophil count of well over 1,000, close to 2,000. if you have a child, now, let me give you a setting of, you have 4 patients, one who's got, a sore throat, one who's vomiting, one who has diarrhea, and a child with leukemia with a neutrophil count of 500. Who's the first person you're going to see? Well, doesn't matter all the diagnosis is, it's that neutrophil count of 500. That child has no immune system. And any child, even healthy children with that low neutrophil count, could go into septic shock quickly. So neutrophil counts are important. Of course, we monitor infections by doing blood cultures and all sorts of cultures, placing them on all sorts of broad spectrum antibiotics. And we know prevention of infections priority, as in hand washing, #1. As I said, with these cancers, you're going to have low platelets. You're going to have low hemoglobin hematocrit. So bleeding is one of those things that you will see. So if these children are in the hospital, we'll be looking, bleeding precautions, looking for it. If they're home, they shouldn't be out riding a bike, jumping off of trees, being typical kids. We need to protect them from hurting themselves, from, falling and cutting and, being around too many children. They're immunosuppressed and getting infections, bikes, skateboards, etc. Anemia, as I said, very common. Hemoglobin hematocrits are low. They're going to be getting a lot of blood transfusions. And remember, because their hemoglobin hematocrit are low, means they have low red blood cells, they don't have enough oxygen, they are going to be tired. We know that chemotherapy causes a lot of nausea and vomiting. When I started nursing, we didn't give an antiemetic till after they vomited. Isn't that ridiculous? Today, we know they're going to vomit, so we pre-medicate, and I like that. I used to have to say, yeah, the kid vomited, and they didn't yet, because I knew they would, and I would give it before. But, that was that little thing I had to do to take care of my patients, and whether they're adult or children. We know they're not going to eat right, they don't feel good. How do you monitor nutrition? And how do we know if they're getting enough nutrition?
Daily.
Absolutely. Height and weight, absolutely. This is the way that we monitor their nutritional status. Whether it is lack of oxygen in an anemia, or is it nutrition, normal, just normal. We'll see them, growth retardation, cognitive delays, but height and weight's #1 things we watch. Now, in these children, we need to give them high protein, high calorie, and full fat. We want to get them the most with every bite they take to give them nutrition, because they're not going to want to eat much. Their mouth, it can be all swollen and red, and it can hurt. And the GI tract goes from mouth to anus. So it could cause the esophagus, the stomach, the intestines to be all irritated. And it could even cause some areas in the rectal area. So we need to be aware of the food. We need soft toothbrushes, maybe a sitz bath, and we're like, well, if we wanted them to eat and the mouth hurt, just give them some lidocaine, right? So that they don't feel that pain. Well, they could choke and they could aspirate, and that would be even worse for these children. So we do not do that. Remember, if you have low blood counts, low platelets, we know that chances for bleeding have increased. So we don't want these children, they're in pain too, right? Remember I told you this girl, she had pain in her knee, she got pain medicine. Well, it causes constipation. What happens when you're constipated? You push and you bear down. What can that cause? It can cause a stroke. So stool softeners, and make sure that we're monitoring stool habits. And of course, giving them that pain medicine as they need, as long as we've treated to keep that bowels moving. We can see blood in their urine, so we need to check on it. So fluids are important. If the kid's not going to eat it, at least giving them IV if they're in the hospital. And then alopecia. Now, I've seen fathers, I've seen brothers, sisters shave their heads too. The one thing that I did is, and I felt it was important, whether they were my cancer kids or my cardiac kids, I would have ribbons, and I would go get those little spools of ribbon, all different colors. And I had a drawer full of them. And when I gave them their bath or when I came on, I would go in, if the kid was alert enough, go, so what color are we going to do today? Are we going to do rainbow? Come on, let's make a ribbon together. And then I'd make a little one and put it in my hair, and they would do their hair, and we'd be the cool twins. And you know, it made them forget about how horrible they felt and that they had no hair. Okay, things you can do, little distraction devices. And then steroids are used. Remember, steroids make you puffy, cushionic, right? And who does this bother the most? Adolescents. So if we know they're on steroids, have them be careful of their salt so they don't blow up even pudgier than they will already. And then make sure that they got a gown if they're wearing hospital gowns big enough, because pediatrics has different size gowns. Or tell the parent, get a size larger. I mean, ever have a shirt that was too tight that you have to keep pulling and it's like it just bothered you? Well, adolescents, what is it? Body image. So make sure that they have that loose fitting clothes so they're not going to be as, worried about that. Always prepare them for procedures. Mostly, as I said, they're sedated, topical anesthetics, using all of those things that we can. And of course, distraction, using child life, use everybody to help you, but especially being honest with your child. Make sure they're medicated for pain. And don't forget, Tylenol is a good one too. A lot of times we don't give the ibuprofen because it has something to do with platelet aggregation. But Tylenol and morphine, whatever, make sure they're getting enough. But remember, it's just not giving medicine. It's also elevating the head of the bed, hot pack, cold pack. It's distractions. It's giving them something to color. It's giving them an iPad to play. It's all of those things all together that work. Now, there's two types of lymphoma. There's Hodgkin's and non-Hodgkin's, and they are sort of the same name, but they're different. So you need to listen to this. Now, Hodgkin lymphoma is the lymph nodes from the clavicles up. You're going to see like these big lumps like you see in this child. And that usually brings them to the doctor. They don't hurt. They don't hurt, but they're big and they look miserable, right? But with that, there'll be a cough, fever, anorexia, all of those things. So that brings them in. So what do? We're going to do a history physical. We're going to find out that they've been tired, they've lost a little weight, they've had a fever, and then this thing came out of the neck, but it doesn't hurt them. So we'll do a CBC, looking for white counts, looking for hemoglobin hematocrit. Of course, uric or liver function, just to check on that. CRP is something called a C-reactive protein. It measures inflammation. And ESR is a SED rate. It also measures inflammation. They'll do the alkaline phosphatase, they'll do a urine to look at it, and they'll do an x-ray to see where is it, is it impeding or squeezing something? Then they're going to be doing, because of this big thing that's sticking there and all of the symptoms, they have a suspicion it's Hodgkin's disease. They're going to do a biopsy, a Sternberg read cell. They'll see in it if it is Hodgkin's disease. How do we treat it? Well, if it's a big lump, they might do radiation and chemo. And usually that's all they need. And actually, there's a great survival rate with Hodgkin's disease. You need aggressive therapy. Remember with radiation, when they put those marks there, that you can't wash them off, because that's where the jet of the radiation gun goes. And we want to have it the same place all the time. Again, make sure these kids are prepared, what's going to go on, so they're not afraid, the noises they may hear. And one thing about Hodgkin's disease is in the treatment, there is a high risk that they're not going to be able to have children. That's the one thing about Hodgkin's disease. Now, non-Hodgkin's is lymph nodes all over the whole body, but you don't see them. They're tinier, they're diffuse, they're everywhere, okay? These things here, they will do the biopsy again, and they'll do those x-rays, but the difference is Hodgkin's, it's from the clavicles up. You see these big non-tender lymph nodes, and when you're looking at non-Hodgkin's lymphoma, it is diffuse. You don't see it, and it's all over the body. You could have these lymph nodes inflamed. They're doing aggressive radiation chemotherapy, again, induction consolidation, just like leukemia, and also treating all of those side effects of chemotherapy, destruction of red blood cells and blood transfusions and platelets and nausea and all those things we're going to be concerned about with this patient. Brain tumors. Now, brain tumors can be cancerous or non-cancerous. And what you see with brain tumors is a child complaining of a headache that gets worse. Okay? It's something that will wake them up at night. They'll wake up, oh, my head hurts. So it's a progression. It gets worse and worse. Also, when you have something growing in your head and the pressure, besides a headache, you're going to be nauseous and vomiting. And it has no correlation to food or eating. It's like all of a sudden you just start vomiting, and a headache is getting worse, and it's harder to treat. It's harder to alleviate. Those are the symptoms you see with a brain tumor, whether benign, whether malignant. Now, with brain tumors, they will go and do radiation and chemo and shrink it because they want it the smallest they can, because they want to remove as least possible brain tissue, because it could be affecting vision, speech, balance, memory, anything it could affect. So we want it as small as possible. Now, when you're talking about post-op brain tumors, remember you've removed a piece of tissue and there's now a space in the brain. So do you lay them on that side or off that side? Elevate their head, don't elevate their head. We really need to follow physicians' orders here. Another thing is, remember fluid balance affects the brain. So strict intake and output. We don't want to overfluid them because it could cause pressure going up into the brain. And remember, these parents, can you imagine having a kid with a brain drain sticking out and, you know, this big incisions? They really need some good support. And of course, our goal is, if they're, you know, come out and there's weakness in walking, whatever, to give them those therapies they need to get them to their optimum functioning. Now, a neuroblastoma is a tumor that starts in the kidney, and it grows, and then we don't really see it. What we'll see is when it already metastasized to the brain. So it's already metastasized before we figure out what's going on. And usually we'll start to see those neurological issues. Maybe the eyes start to bulge out or some ecchymotic because of the pressure pushing it out. These children, once we figure it out, as I said, they already had metastasis. So these children don't really do well. We do give them chemo, radiation, we do surgery, but the outcomes aren't as good as we really would like to see. It's very rare, thank God, because it is a very difficult condition. And then osteosarcoma, bone tumors. Now, bone tumors, actually, the biggest one we'll see is on the femur. It's usually adolescents. And the treatment is we've got to take the whole bone out, which means from the hip socket down to the knee, that bone has to be gone. How do we know when a kid has this osteosarcoma and what would we see? Well, these are children that you would see that start to limp and it gets worse and it starts to hurt. They start to get pain. Then you start swelling. Then you start seeing weight loss, getting infections. And then we'll say, okay, let's do an x-ray. And you'll see like a fuzzy little area there. They might do a bone biopsy, but what they need to do is, number one, try to do chemo and shrink it, keep it contained. And then they need to get that femur bone out, okay? Now, if we don't have something to put up into that hip socket, how are we going to place on any prosthesis so they can walk? And like I said, these are adolescents. So what they do is what we call salvage the limb. They take the lower leg from the knee down and put it up into the hip socket and create a place where you could place a prosthesis so that they can walk. Look at that picture down there. They've took the lower leg and actually the foot's facing backwards. And then they could put a prosthesis on and teach them how to walk. It's better than not having anything, right? Sometimes they do have to amputate the whole leg, but the goal is to salvage the limb and have it there for that prosthesis. Wilms tumor is another kidney tumor. It is in African American boys, mostly ages 3 to 5. I've seen one in my lifetime. Remember that Haitian earthquake several years back, maybe 10 years ago? And our hospital sent a lot of our nurses and doctors down there. And they found this little boy with this tummy, and they found this Wilms tumor. What they did is they got some sort of religious group or something and got him over, and these people, and they had a pack of papers, all in French, of course, and they had these people pick him up, and they said, bring him directly to the hospital where I was the triage nurse. And I said, so what's going on? And they go, I don't know. They just told us to pick him up and bring him here. And here's the papers. And I'm like, they're in French. So as a triage nurse, where am I going to put this kid in the ER? Is it critical? Is it non-urgent? What do I do? So I have to do an assessment, right? I got to figure it out. So I did a set of vital signs. They're normal. I listened to the lungs, looked at the eyes, and then I listened to the abdomen. And when I got to the left lower quadrant, I felt a softball-sized hard mass. And somehow, some way, and I'd never seen it before, I went, this is a Wilms tumor and we can't touch this anymore. You'll see this in your career. All of a sudden, you'll remember something at a nursing school or something you read or something, and it hit me. So I knew where to place the kid. We got him back. Yes, it was a Wilms tumor. And in the end of the story, the kid did well, went back to Haiti to his family. But it was like one of those things, what do I do? Well, Wilms tumor is a tumor off the kidney. It is cancerous, but it's very fragile. You cannot palpate it, touch it, because little pieces can come off and cause metastasis in the peritoneal area. And we don't want that. Also, we don't do biopsies because now you are opening it up for it to go into the abdominal area, right? We don't want that. So big caution, do not palpate abdomen. A sign on the chart, a sign over the head, a sign on his forehead if you have to. Don't touch that abdomen. So what they do is, they went and found somebody to read the chart on this child. We did an ultrasound. We didn't want to rub that belly. We did a CAT scan, and we got this kid ready for surgery. What they did is they did chemotherapy and they did surgery on this child. They did there's very good survival rates. Now, the big thing is, again, changing the diaper on this child. The kid was 3, he was still in diapers. You have to be careful. And we have to make sure that people didn't touch it, because that could have altered his course of what's going to happen. Now, that is actually the size of the type of incision, because you can't make a small one and squeeze it out, because what are you going to do? Manipulate it, and you're going to have pieces of that tumor left behind. We don't want to do it. So it's a big incision. Now, it's from the kidney, so you have to monitor your urinary function postoperatively. Plus, there's a lot of manipulation in the GI tract, so we have to monitor bowel function also. But this kid did well. He went home, and it was one of those things that I'm like, how did I remember that? But you'll see, you'll do it too. Rhabdomyosarcoma is little areas from like the nose, the eyes, the ears, and it is a cancer. And you might just see something big growing, and of course it will need surgery. Retinoblastoma is a cancer of the pupil. And I seen one of these, and it was like an 8-month-old little girl, and you see white. Did you ever open the door and look in the backyard, and there's a cat or a dog or a deer or something, and there's a light on, you see like this white shine? That's what this looks like. Those eye looks like that. They call it a whitish glow. It's like a cat's eye, they call it, another name of it. And it is cancerous. How do we treat it? Well, again, irradiation. You see that little purple mark? Don't wash it, leave it there. They'll do chemo, and then they're going to do surgery, and they remove the whole eye. They have to take it all out. Now, as we are getting this child and doing a history and a physical to figure out what level of treatment and how invasive we need to be, we need a detailed family history about the eye signs and symptoms and how long it's been going on, because this could be metastasized already. But if it just happened, those chances are minimal. But if it's been there for 2 months, you've done nothing, then you're going to have to do a detailed go into and really look for cancer on this child. Again, this child's not going to have an eye, he's going to have a false eye, and you need to prepare the family for that. In high school, I remember this one boy had a fake eye. He used to take it out and roll it around on his desk in school, and it used to gross and gag everybody. Then he'd put it in his mouth and lick it and stick it back in his eye. It was like, oh my God, I'll never forget it. It was like, thank God I was going to be a nurse, so I was trying to handle it, because I'm trying to be this tough girl, but oh my God, I still remember it, and that's a long time ago.
So there's no way for them to keep that eye. Like if they have that, it's automatically going to come out.
It comes out. It comes out. They have to get the whole thing, or it's going to metastasize. Yeah, it's pretty sad. But at least they have one eye and they're going to live. So you have to look at it that way. But yeah, germ cell tumors. I think of these, and I think of males and testicles and testicular cancer. I saw one of these. 18-year-old boy come in complaining of testicular pain. And testicular pain is a true and real emergency, because what if it's just a torsion? And that torsion is what we need to untorsion that, so that this child can have a, be able to get pregnant, and have babies. Now, this boy, apparently he said it had been going on for about a month. And the other nurse in the triage room was doing the assessment. She said, okay, pull down your pants. And she had her gloves on, ready to squeeze to see where it was. And it was the size of a softball. They brought him back into the back, and the doctor looked at it, and they did a chest x-ray, an abdominal x-ray, and they did an ultrasound of the testicle. It already had metastasized throughout his whole body. That 18-year-old boy probably had it longer than a month, and in 3 months, that little boy died. It was one of those things that you don't forget. Liver tumors, remember livers, you can take out a piece and they will regenerate. And they actually do really, really well. Childhood cancer survival, we know that today they survive more than ever. We know that there's been so many advances that, you know what, 40 years ago, I mean, I've been a nurse, what, 46 years now? I don't know, forever I've been a nurse. And it's like what used to be and what's now and what we can survive. It's just amazing. So many treatments are there now. So I love it when you go to Facebook and you see those kids or those adults saying cancer free. Just makes me smile because I know what they've gone through. Amazing little stories I always have for you, don't I? Now we have our cahoots. It's we only have about 17 minutes left. I can do two things for you. We can go over it. It's 40 some odd slides of cahoots, or I can send you a recording and the decision's up to you because I know it is late. What do you want to do? I do a cahoots?
Send recording.
Okay, that's one. Okay.
I think
who wants-
send the recording.
Okay, I'll give you my early morning class. Put your hand up if that's okay.
Yeah, we have a test next week.
Okay. I will send
Yeah,
you.
we have a test this week and we already had a makeup class, so we're doing double time today.
No, I understand. That's why I'm asking you. A lot of information this week, so I wanted to make sure that you got that. But if that's what you want, I will send it to you. Remember, those cahoots are very important, so you make sure that you do go over it, okay? And I'll get that out tomorrow for you.
Is there a way that you can send like a link so we can actually get on and do the cahoots ourselves instead of just watching the recording?
I send it every announcement.
So
Every week you have a cahoots to that week.
yeah, so usually when I click on that, it just takes you to, like, you can't actually play the game. It just takes you to like the site where you can
You
look at the
need-
questions.
You need two people to play it.
Oh,
You
okay.
can.
Okay,
So
gotcha.
have two devices.
Okay,
Have a computer and your phone. You could play with yourself.
okay,
You
gotcha.
can
Thank
do
you.
that.
Okay.
No, absolutely. And again, if you have any questions with it, let me know.